Welcome to AETCM, the emergency medicine channel. Today we'll discuss about hypercalcemia. Levels of calcium is increased in our body, that is hypercalcemia. So we'll discuss about the reasons for hypercalcemia, clinical features, how to investigate, how to manage. Calcium is very important for bone formation. We all know that bone formation is done by calcium and vitamin D. Around 99% of the calcium is in our body bones, and only 1% is there in the extra bone compartment. 99% is remaining in the bone, teeth, all these things. Then 1% is in extracellular fluid. 50% of the serum calcium is ionized or free, and other 40% is bound with albumin, and some are bound with phosphate, something like that. So calcium balance is regulated by two important hormones. One is parathyroid hormone and vitamin D. Vitamin D also, even if it is a vitamin, we consider it as a hormone here. PTH stimulates the bone resorption, promotes conversion of vitamin D to calcitriol. So that is the action of PTH. Mainly PTH is the parathyroid hormone. So above thyroid gland, we know that parathyroid hormones are there that releases parathyroid. The parathyroid glands stimulates or releases parathyroid hormone that controls the calcium. Again, that depends on the levels of calcium. When the calcium levels are high, that secretion reduces. The levels are low, then increases. Like that, various mechanisms are there to control this calcium metabolism. We are not going to the details of that. But whenever calcium is low in our body, parathyroid hormone is released. That act on the body and various organs in the body, especially bone, kidney, and intestine. In bone, it releases calcium from the bone. Kidney, it reduces the secretion of or excretion of calcium through the kidneys. Intestine, it increases the absorption of calcium. That is the action of parathyroid hormone. Parathyroid gland, you know that it is just situated just above the thyroid gland. Now, whenever we see a patient's calcium, we need to correct the calcium level according to the albumin. So, corrected calcium is mainly required in hypocalcemia than hypercalcemia. That whenever there is hypoalbuminemia, you have to correct it. So, the formula for that is serum calcium. There is an amount we are getting in the lab investigation plus 4 minus serum albumin into 0.8. That gives you the corrected calcium level. This is especially very important in patients who is having hypocalcemia rather than in hypercalcemia. But when we are dealing with calcium, we should know all these things. And normal value 8.7 to 10.2 milligram per deciliter. More than that, we call it as hypercalcemia. Now, hypercalcemia is more than 10.2 when the albumin levels are normal. Among all the causes of hypercalcemia, you know that hyperparathyroidism is one of the important conditions which can produce hypercalcemia, and malignancy also can produce hypercalcemia. These two things have got some similarities. Both the conditions, calcium levels are very high, but hyperparathyroidism induced hypercalcemia can easily be controlled, but malignancy related hypercalcemia, it will be very difficult to treat the patient because it's a continuous and intensive process. That is very important. The higher calcium levels, clinical features, symptomatic patients, and difficult to control, all are features of malignancy related hypercalcemia. Now, pseudo hypercalcemia is mainly depending on the patients who is saying hyperalbuminemia, especially patients who is saying multiple myeloma. Multiple myeloma as such patient can have hypercalcemia, but along with that, it also depends on the albumin level or protein level. That levels can further increase. But clinically, this does not have major importance. We treat hypercalcemia mainly depending on the clinical features. Now, there are different causes. You can remember the causes by knowing this mnemonic. that is chimpanzees, calcium excess, administration or over supplementation of calcium, but this is a rare condition unless until you give IV calcium or patient is having a renal failure and give excess calcium. This will not happen in clinical practice. Hyperparathyroidism is one important cause which can produce hypercalcemia. Hyperparathyroidism can be primary, lithium induced or familial. Then prolonged immobilization can have hypercalcemia. Multiple myeloma is a very important condition where patient can have lytic lesions in the major bones with hypercalcemia. Multiple myeloma, alkaline phosphatase will be normal. Remember, multiple myeloma is a bone lytic lesion. Even then, alkaline phosphatase will be normal. But whereas in other lytic lesions, because of malignancy, other types of malignancy, calcium levels will be low, high. Even alkaline phosphatase also will be high. Parathyroid gland adenoma is another important condition. Aluminum intoxication, neoplasms like breast cancer, lung cancer, metastatic bone lesions, paraneoplastic syndrome, Zollinger-Ellison syndrome, excessive vitamin D intake. Nowadays, we are seeing almost all patients, if you check the vitamin D, levels are very low. So patients are started taking vitamin D continuously. If they take more than 3 to 4 months of vitamin D, you can see vitamin D excess, and sometimes it can go to dangerous hypercalcemia. Sarcoidosis is another condition where you can get hypercalcemia, and all other causes are listed on the opposite side. You can check it. This is only a mnemonic you can easily remember as chimpanzees. Now, symptoms are very important in hypercalcemia: bones, stones, abdominal groans, and psychic moans. Bone pain is main important thing. It is mostly seen in parathyroid-induced hypercalcemia, and even in malignancy, multiple metastasis, bone fractures, all these things also seen in bones. Stones means kidney stones. Most kidney stones are formed by calcium phosphate and calcium oxalate. Groans, abdominal smooth muscles are not contracting as much. Patient can develop constipation, abdominal pain. Moans, lethargy, fatigue, confusion, depression, anxiety, hallucination, irritability, etc. So if you remember this mnemonic, bones, stones, abdominal groans, and psychic moans, you can remember most of the clinical features of calcium deficiency. But remember, calcium deficiency normally present with minor fractures. Small trivial injury can present with fractures. That is a most common presentation of hypocalcemia, all these things. Clinical features generally occurs when serum calcium more than 12 milligram per deciliter. Many patients are asymptomatic. Osteopenia, fractures, bone pain is very, very common because bone is losing calcium from that sometimes. And many a times you can see pathological fractures are due to malignancy, infiltration of bone by malignant tissues. Then kidney polyuria, nephrolithiasis, renal failure, kidney stones, GIT, abdominal pain, anorexia, vomiting, constipation. Nervous system is another important thing. Many patients can present with altered behavior. That is one of the important clinical findings of severe hypercalcemia. Arrhythmia is also common. ECG shows short QT interval that we'll see afterwards. One of the important investigation other than serum calcium is ECG. ECG, what you are seeing here is short QT interval. In severe hypercalcemia, even Osborne curves are seen, that is J point elevation. This is also seen in hypothermia also, so it is not a important finding in hypercalcemia. It can be seen in other conditions also. Ventricular irritability and ventricular fibrillation is another major finding. So shortening of QT interval is very important in patients with hypercalcemia. So any patient who is having hypercalcemia, always remember to take a ECG and rule out a short QT interval. Now, blood investigation. Once you make a possible diagnosis of hypercalcemia, you should remember conditions like patient is having previous malignancies, hyperparathyroidism, patients is having multiple myeloma. All these patients can present with altered behavior, severe bone pains, ECG short QT interval. Then you have to check the calcium level along with serum albumin. Albumin has got a limited role in hypercalcemia than in hypocalcemia. Hypocalcemia serum albumin has got a very important role to correct the calcium. So serum calcium should be checked. If the calcium levels are more than 10.2 or 10, then you can think about hypercalcemia. Then the first investigation you do will be serum PTH, parathyroid hormone. If the parathyroid hormone is normal or elevated with elevated urinary calcium, then it is hyperparathyroidism. Low urinary calcium is familial condition. If the PTH is low, less than 20 picogram per ml with hypercalcemia, suspect a malignancy. PTH related peptide, that is a paraneoplastic syndrome related hormone. Chest X-ray should be taken, bone scan should be taken, multiple myeloma workup should be done. That we'll discuss elsewhere. Multiple myeloma workup means urine Bernstein protein, then protein electrophoresis, all these things you can do. Chest X-ray, angiotensin converting enzyme can be done in sarcoidosis. ACE levels can be elevated in sarcoidosis. Phosphate, low phosphate, elevated alkaline phosphatase is primary hyperparathyroidism. High plasma phosphate, alkaline phosphatase with renal failure, tertiary hyperparathyroidism. So depending on all this investigation, you can make out a possible diagnosis of reason for hypercalcemia. So basically we do a PTH level, urine calcium level, and alkaline phosphatase, and serum phosphate, renal function, that is creatinine. Now, how to manage a patient with asymptomatic hypercalcemia? Like many patients, you can see patient calcium level may be 12 or 13, but they will not have any symptoms. So, no immediate intervention are required in emergency room. Mostly, their calcium level may be less than 12 milligram per deciliter. And if there is mildly symptomatic patients, that is calcium for 12 to 14 also, does not require any acute treatment. You can wait and slowly start the treatment. But when we are discussing with hypercalcemia, whether it is acute hypercalcemia, symptomatic hypercalcemia, asymptomatic hypercalcemia, you are supposed to reduce the calcium in emergency medicine department itself. That is by giving lot of water, fluid, IV fluids, rehydration. We have to, patient will be losing large amount of water through the kidneys, since the hypercalcemia can produce some diuresis. And if the calcium levels are more than 14 and symptomatic, rehydration is an emergency. Initial therapy of hypercalcemia starts with volume expansion. That is because I already told that hypercalcemia can induce some amount of dehydration and volume loss, along with diuretics, because you are giving IV fluids to expand the fluid inside the body, but at the same time we have to remove the calcium through the kidneys, so that the calcium will be removed, volume will be expanded. So you have to give fluid, you have to give Lasix, that is furosemide, that's a diuretic, that also should be given along with the fluids. So IV fluids 10 liters per day. Normal saline is the preferred drug, along with IV furosemide. Furosemide is a diuretic, so 80 to 100 milligram can be added to the IV fluid, or you can give separate infusion. Initial rate of normal saline will be 200 to 300 ml per hour. Then it is adjusted according to the urine output. You have to maintain a urine output of 100 to 150 ml per hour. So high urine output is required. Through the urine, patient can pass the calcium out. Next drug is by bisphosphonates, like zoledronic acid, that inhibits bone resorption. So that can reduce the release of calcium from the bones. If there is an increased calcium mobilization from the bone, especially in malignancy or severe hyperparathyroidism, bisphosphonates can inhibit bone resorption by an interference with osteoclast recruitment and their function. Ideal drug, that is an IV bisphosphonate, that is zoledronic acid, 4 milligram in 100 ml normal saline, and intravenous infusion over 15 minutes or pamidronate 60 to 90 milligram IV over 2 to 4 hours, and another drug is etidronate, that is 7.5 milligram per kg per day into 3 to 7 consecutive days. You have to reduce the calcium. So we have to be very careful when we are giving this drug. If renal failure, somehow these drugs are not safe. So we have to be very careful, especially patients who is having renal failure induced by hypercalcemia. You can give fluid and reduce the serum creatinine, and then you can start. Denosumab is a human monoclonal antibody which binds with RANKL, preventing RAN from binding osteoclast. So this drug also can be used to treat the patient who is having hypercalcemia. that is used in patients who is having refractory hypercalcemia. In spite of using the dose of bisphosphonate therapy, this can be tried. The dose is 120 milligram subcutaneous every 4 weeks. Every month you have to give 120 milligrams. So chronic hypercalcemia and all, we can try this drug. Now, steroids are mainly used to prevent the absorption of calcium from the intestine. So, it also increases the excretion of urinary calcium. So, both ways it is very useful. Multiple myeloma, it can be used, but the main usage is in sarcoidosis. That is a condition where there is an like granulomatous lesion which releases the calcium. So, that lesion also will come down, calcium excretion also will be coming down, and calcium like exit through the kidneys also will be promoted. Intestinal calcium absorption will be reduced. So there are multiple actions for this drug. The dose of the drug is hydrocortisone 100 to 300 milligram daily, or oral prednisolone 1 to 2 milligram per kg body weight can be given. So that also given for 3 to 7 days, 1 week you can give. Salmon calcitonin can also be given in patients who is having hypercalcemia. 4 to 8 international units per kg IM. That is an important thing. Salmon calcitonin we can given as a nasal spray, but here it is not. Nasal spray is not effective in treating hypercalcemia. That is effective in osteoporosis, not here. So 4 to 8 international units per kg IM 6th hourly should be started. It increases the renal calcium excretion and decreases the bone resorption. So two actions are there. Now this chart will tell you how to evaluate and treat the patients with hypercalcemia. Whatever we explained in the previous slides, it is given here. One important thing we didn't discuss, that is dialysis. If the patient's calcium levels are very high, we are not able to treat the patient with fluid because of cardiac failure, kidney failure, whatever it is, not able to give the bisphosphonate because of the renal failure, dialysis will be the option for that type of patients. So a patient who is having severe hypocalcemia, not responding to your treatment, or not able to give adequate treatment because of the cardiac failure or renal failure, dialysis can be tried in that type of patients. So we have discussed about some preliminary and important features of hypercalcemia in emergency room. Hypercalcemia normally present with altered behavior, muscle pain, sometimes seizures, all these things. Calcium levels are high mainly because of two important reasons. One, it is a malignancy. Malignancy itself, there are bone lytic lesion or paraneoplastic syndrome. Another important cause is parathyroid hormone excess. These are the two important conditions. But when you compare with these two conditions, parathyroid hormone excess hypercalcemia is easy to treat, whereas malignancy induced hypercalcemia is difficult to treat and they have more symptoms than hyperparathyroidism. Thank you.